Okay, everyone. Welcome to today's case conference. I'm going to start things off. This is Phil Young from the Mayo Clinic. Can you see my screen?
Not yet. I'm gonna share the screen with you in just a second. This is Jacob Kirsch over in Florida. Let's see. Phil Young, make presenter. Take it away, Phil. Thanks for doing this.
Hey, you bet. All right. Is this showing on people's screens?
Not, you have to accept it.
One more time. Let's see. It's not letting me accept. Did you invite me specifically?
Yeah, I just made you the presenter.
Become the presenter to start sharing your screen. I don't see the invite to accept your.
All right, let me do it again.
Still not. I was working a minute ago.
There you go. Got it?
Thanks. All right. How's that?
I can see your screen. Perfect.
All right, everyone. So I'm Phil Young from Mayo Clinic. I thought I'd start things off. It'd be great if we have some other people who want to add their cases as well in this. But what I thought I'd do is actually start off with some of our experience from our ED practice and our acute chest pain CT clinic. Let's start right off here. We've got a 90-year-old female. She's got acute 8 out of 10 burning chest pain, which progressed into her shoulders, across her chest, and into her back. ECG shows inferior ST elevation. Her initial troponins elevated. She started on aspirin, heparin, and nitro, and sent on an ambulance to our emergency room. And you may think, well, wait a minute, this isn't the kind of patient that ought to go to a CT. This is somebody who should go to the cath lab. And you're right, except that she's 90 years old. She's very with it, and she's very clear. She doesn't want aggressive measures, specifically no surgery and no catheterization. So in this case, the referring doc is in a little bit of a quandary, and ultimately has to decide: is this ACS? You want to confirm the diagnosis, exclude competing diagnoses, and stage how severe the problem really is. So in this case, we did a triple rule out CT. So triple rule out, for those of you who are not aware, aorta, pulmonary embolus, and coronaries. And what you can see here is there's an acute occlusion of this obtuse marginal branch of the circumflex right here, and there's a downstream perfusion defect in the myocardium. And we retrospectively gated this exam. Certainly, we do more of it than most places, but we think radiation doses is a marginal concern, especially in somebody who's 90 years old. And in this case, you can really get a beautiful depiction of the infarct itself. You see the wall motion abnormality here. You see a perfusion defect that correlates beautifully with the occlusion of the OM branch. There's even the posterior medial papillary muscle you can see here is ischemic or infarcted. You can calculate an ejection fraction. And I think this is a really powerful approach, again, to really highlight the value of CT in both detecting the lesion and staging the sort of the severity of the problem here. Now we're doing more and more of these, and in fact, our cardiology clinical practice committee has asked us to sort of take ownership of this problem in our practice, because so many patients come in with chest pain, and there's a tendency to try to get a CT to rule out pulmonary embolus or dissection, and then start the workup for ACS. And the reality is there's an opportunity up front to evaluate somebody's coronaries and kind of risk stratify for ACS. And statistically, the risk of a low to intermediate risk patient having ACS is about the same as finding a PE on a PE study or a dissection on a dissection study. Statistically, those patients are about as likely to be having ACS as the thing that we do all the time. And so we're seeing more and more cases like this, where patient comes in with chest pain, gets the dissection CT, and if you look at this kind of basal lateral wall here, it may look a little bit dark, and the more aggressively you window it, more like a brain window, you'll see that there's a perfusion defect here. And particularly if you reformat it in the, excuse me, I'm going backwards here. if you reformat in the short axis and thicken your slices and maybe change from a grayscale to a color window, all of a sudden it's amazing what you can see. I mean, this looks like the best nuclear perfusion study in the history of the world. And in fact, this was a dissection CT where we weren't even trying to look at the heart. It's just incidentally we could see this perfusion defect here in the basal inferolateral wall. And this patient actually was admitted to cardiology, went on to have a cath, and has this stenosis here in this OM branch, which perfectly correlates with the perfusion defect. What we tend to see in these cases, we're doing more and more cases, as I think we all are, where we're either ECG gating studies or we're doing them with high temporal resolution, for example, a flash PE study. And essentially what you see are things like myocardium is too thin because it's not contracting, it's ballooning out, it's too dark because it's not perfused well, it conforms to a coronary distribution. And sometimes you can see wall motion abnormalities even if you just fortuitously happen to image in systole. Here's another patient ordered a dissection protocol for intrascapular chest pain. This is an 86-year-old guy with intermittent right chest pain while mowing his lawn, had a dissection CT. And you just happen to have imaged here during systole. You can see that there's extensive atherosclerosis in the LAD, and there's a wall motion abnormality and a perfusion defect here downstream from it in the LAD territorial myocardium. And if you put this on the short axis again, you can see there's a subendocardial perfusion defect that really beautifully corresponds to the LAD territory. We certainly saw the atherosclerotic plaque beforehand. And I think there's a big difference between saying no dissection and saying no dissection, but extensive atherosclerotic plaque in the LAD and what looks like a perfusion defect downstream from that in somebody with acute chest pain. This patient went on to cath, and you can see here this was pre-stenting. Another one, this was actually a PE study. It says orders a PE study, but the question was PE or dissection. And again, you see here the subendocardial perfusion defect in the kind of mid-ventricular to basal lateral wall. If you put these in our PAC system, it's easy to switch from a grayscale to a number of color presets. And if you thicken the slices and make it an average intensity projection, it's fairly easy to do this. And so I think we're seeing more and more of these cases where we're moving toward a more standardized workup in our practice for chest pain with CT. Instead of having a PE study or a dissection study, we kind of treat them all the same as a triple rule out. And I think that, the more of these cases you look at, they all start to look the same. The perfusion defect here in the LAD territory, you notice that's thinned. It's maybe a little sharper than the rest of the myocardium because it's not contracting as well. And again, correlation. Another dissection study, we routinely recon these anyway with a small field of view, because if you have a dissection, you want to see, is it extending to the commissures of the aortic valve, is it extending to involve the coronary ostia. And again, you see an occlusion here of this LAD, you see a downstream perfusion defect, and it's amazing how much once you start doing these, you can see. And in fact, in our practice, once we started ECG gating dissection studies, the main difference between a dissection study and a triple rule out was, do we reconstruct small field of view images and do we look at the heart? I mean, that's really what it comes down to. And again, here's this confirmed with cath, that abrupt occlusion of that LAD. Here's another one. They all start to run together after a while. Thrombosed right coronary artery aneurysm is somebody with acute chest pain. And again, you see this perfusion defect in the basal inferior wall that corresponds to it. A 69-year-old male with chest pain and a history of an aortic aneurysm. And again, if you're looking carefully, you can see there is an LAD stenosis, 69-year-old guy with chest pain. It's important not to miss that, I think. And again, pretty subtle, but there's a little bit of subendocardial hypoattenuation, and it's a little bit thinner there. And we just happen to have imaged during a partially contracting phase of the cardiac cycle. Again, confirmed here at cath. And then what's interesting is once you start doing more and more of these sort of ED, acute chest pain type cases, you start finding some really interesting things. Here's a 45-year-old male with intermittent left anterior chest pains radiating to the left upper extremity for 5 days, preceded by heavy lifting while camping. He was a smoker, hyperlipidemic, presented to the ED, had an initial troponin that was slightly elevated, a normal ECG. I had read this chest x-ray, and I missed actually a subtle finding here projecting over the heart, which comes out to be relevant shortly. So this guy goes on to the cath lab, has normal coronaries, but is found to have this little metallic density, which is moving back and forth throughout the cardiac cycle. And so this guy was rock solid stable. And in order to sort of further characterize this, the patient was sent for a CT. And in fact, what you'll see here is there's a metallic strut here in the RV apex, which has perforated the interventricular septum and is perforated the RV free wall. And there's a hemorrhagic pericardial effusion. And of course, this patient had gotten Plavix on his way to the cath lab, so that's somewhat concerning. And you see here again in short axis, you can see this is the little metallic density. This is the hemorrhagic pericardial effusion. And I had gone back before the CT and looked at the chest X-ray and saw his IVC filter, so we scanned a little lower. And if you compare to a prior study, you can see that one of the tines is now missing. So presumably this guy is out, camping, and he's doing this heavy lifting with an extra tine in place. And as he's doing this straining and lifting, it pops off and flows northward, and is now sitting in the apex of his right ventricle, having perforated the myocardium and causing this hemorrhagic pericardial effusion. So this actually went to surgery. There were no serious bleeding complications, and the filter was subsequently removed. 33-year-old female, 4 days postpartum, presents for evaluation of cough and shortness of breath, CT angio to rule out PE. And I think, again, the pretest probability of PE causing this is fairly low, but it certainly could be a peripartum cardiomyopathy. You could have a SCAD. And so this patient was switched to a triple rule out CT. And you can beautifully see there's CHF, right? There's smooth interlobular septal thickening. There's pleural effusions. There's a dilated left ventricle here with normal coronaries. So great example of somebody with peripartum cardiomyopathy. This is somebody who actually came in with chest pain and actually had a free rupture of the right atrial wall. And in fact, as you see this contrast kind of floating back and forth between the right atrium and the pericardial space, you may notice that there are actually little hyper enhancing nodules throughout this pericardial space. And this is actually a right atrial angiosarcoma, which has ruptured. And probably the reason the patient didn't immediately decompensate in tamponade was because there was tumor infiltrating all the way through this pericardial space and sort of constraining the rupture and preventing tamponade in this case. So a tragic case, but if a surgeon is going to go in there and try to repair this, it's a lot better if they know what they're getting into with this big mass right here. And can you imagine trying to sew together friable hypervascular tumor? I think they need to be prepared to know what they're getting into in this case. 57-year-old male in the ED ordered a PE study because of a shortness of breath and elevated D-dimer. What you see here is, again, sort of an LV chamber enlargement, looks like CHF. He had 4 weeks of shortness of breath and fluid retention. We saw he had CADRADS 1 disease. We retrospectively gated it, calculated he had a severely reduced LVEF, 22%. And this is a nice case of a non-ischemic cardiomyopathy. Doesn't need to go to cath, doesn't need to have a stress test, doesn't even really need to have an echo to confirm the EF in this case. It's a one-stop shop. 42-year-old male, history of aortic insufficiency and hypertension, presenting with shortness of breath, chest pain. His abdominal aorta was noted to be pulsatile on exam, and a CTA was ordered to rule out a dissection. And so this guy was actually a refugee who had very fragmented medical care. And you can see there's some fairly subtle left ventricular chamber enlargement and hypertrophy in this case. And even though we didn't actually gate this, we did flash it, which increases the temporal resolution. And what you can see here is that he's got a quadricuspid aortic valve with central non-coaptation. And when we reconstructed the images at coronary resolution, we could also clear his coronaries. So you can clearly see this is not acute ischemic process. He has no significant CAD, but this is end stage kind of burnt out dilated LV failure because of this quadricuspid aortic valve with insufficiency. And the reason he had this pulsatile abdominal aorta was because of his stroke volume, and he finally had just decompensated. And so this patient, we didn't need any angiography pre-op to clear his coronaries. He went for an aortic valve replacement. And this is a nice correlation here of this quadricuspid aortic valve with the central non-coaptation between the CT and the operative photos. Kind of a beautiful correlation in this case. 79-year-old man with a history of atrial fibrillation on Eliquis, secondary to a non-provoked PE 1 year ago, presents with syncope found to be in ventricular tachycardia status post-successful cardioversion. He was begun on an NSTEMI protocol, and a PE-CT was ordered. I looked at this and thought, this guy doesn't need a PE-CT, right? He needs a more comprehensive, cardiac workup. And the first thing I saw as we were doing this triple rule-out CT was that, in fact, he's got this coronary vascular malformation, and you can see that he's got these kind of collaterals, that involve certainly coronaries, but also draining into the pulmonary artery and connecting with bronchial arteries higher up. So you look at this kind of bigger fistula here to the pulmonary artery, which is a little bit dilated. And then you look up a little higher, and here's the bronchioles coming down. I spent probably 20 minutes trying to map this out and say something that was both concise and useful about all of this kind of funny anatomy. And I still couldn't figure out, how does that ultimately tie back to the fact that this guy presented with syncope and was in VTAC, and it doesn't really make sense to me how this all fits together. And as I was looking over all this anatomy and turned my head to look at the record, and finally turned back and looked at this, and all of a sudden the images jump out at you and you say, look, there's actually diffuse fatty infiltration of his RV free wall. You can see there's areas of dyskinesis in a dilated right ventricle. This is somebody who has ARVC. And in fact, we were able to use this CT to trace his RV ejection fraction and index his RV end diastolic volume. And I would argue that this patient doesn't need an MRI. You'll never see better images than this for quantifying and evaluating RV function. This is somebody who meets two major criteria for ARVC. Pretty powerful. 24-year-old female began sort of having chest pain with extreme exertion, now chest pain and palpitations worsening on dyspnea on exertion. And this is another patient who kind of had a triple rule-out CT. And in fact, what you see here is that there's another quadricuspid aortic valve, and there's a sinus of valsalva aneurysm, which was protruding into the right atrium and has actually ruptured here, which is kind of a striking case. But it's this finger-like projection coming off of the accessory coronary sinus, which again is ruptured and is now causing this left to right shunt and causing this dyspnea on exertion and chest pain. So again, volume rendered images really show this a ruptured sort of right aortic sinus with a new shunt associated with an underlying deformity from a quadricuspid aortic valve. Right there. And that's what it looked like. See if I can show you what it looked like at surgery. From the right atrial side, you can see this finger-like projection here that it actually ruptured and was subsequently repaired. 2-year-old boy with suspected Kawasaki arteritis. This is an otherwise healthy 2-year-old who presented to the ED with concern for prolonged fever. He first developed a fever 3 weeks ago. Parents measured it as high as 39 degrees. They gave him some acetaminophen. The fever came down, didn't have any other localizing symptoms. Next morning was afebrile, so the family went to the zoo. He did vomit and spiked another fever. So he went to a GP the next day, and this was a family from a remote farming community, didn't have easy access to medical care. And the GP noted having juncted conjunctiva and some tender macular lesions on the hand and feet. But he did have exposure to a friend with hand, foot, and mouth disease. So the presumptive diagnosis of hand, foot, and mouth disease was made, sent home with instructions to continue giving antipyretics as needed. And I think this is a case where the family took the advice very literally. And again, it was not easy to get to medical care. But over the next week, he had continual daily fever, was given round-the-clock acetaminophen, continued to have low poor intake and urine output. At times, the parents had to feed this 2-year-old by syringe, by mouth. For several days, the fever resolved and had slightly improved, and then he redeveloped and became increasingly concerned because they developed a desquamating rash around the fingers and diaper area. Lips were now so dried and cracked they bled. Extremely injuncted conjunctiva bilaterally. Intermittent blotchy rash on the dorsum of his hands and feet. And the family was in contact with the GP, who said, you know what, you really need to go to the emergency department because of concern for Kawasaki's disease, given the prolonged fever and these findings. So the patient came in and had what looked like an anterior infarct on ECG, which of course is highly concerning given this clinical history. And this patient went to a coronary CT. We actually had the patient on an esmolol drip. It came down from the PICU. And I think you can beautifully see the coronary aneurysm here of the right coronary artery. You can see the circumflex. And you can see the left main and LAD, which actually has thrombosed in this case. And although, radiologists, we tend to think of Kawasaki's is the disease that causes aneurysms, it's actually the stenoses that get the patient in trouble, or in this case, the thrombosis of an aneurysm. So really, I think this became sort of the new baseline to use to follow this patient with extensive disease. And we were able to, again, to calculate LV function off of this, look at the regional wall motion abnormalities, sort of characterize the size of the infarct, and again, use this as a baseline for follow-up in somebody who clearly has a very serious problem that's going to need long-term surveillance. So he was given a steroid pulse for 3 days, anticoagulated. Follow-up echo suggested that thrombus in the LAD was developing further. Gradually improved his LVEF to 44% at the last echo, and has actually done very well and had minimal symptoms. So kind of remarkable how resilient some of these kids can be. Here's a 33-year-old woman who was brought to the ED by rapid response team. She was visiting her grandmother in the CCU and collapsed when informed about withdrawal of care for her grandmother, and had no preceding symptoms. So this sounds just sort of like an acute, sort of almost like a vagal type event where she's given bad news and just collapses. But they called a code, and the code team reported her unresponsive, and she was reported to have a wide complex rhythm which degraded to VFib. Now there's no rhythm strip available. This is according to an intern who's been carrying the defibrillator, and looks at this at the rhythm and says, oh, that looks like a wide complex tachycardia that turned into VFib. So hard to say. We've got some very smart interns, but of course they're brand new and don't have a lot of experience too. She underwent ACLS and was defibrillated. So the device actually agreed with the intern on this, and she received CPR and a milligram of epi before return to spontaneous circulation. On arrival to the ED, she was alert, she was cooperative, but confused and disoriented. She didn't have any neurologic symptoms. She couldn't remember anything about the day and even much of the last week. The family reports she'd been under a lot of stress related to grandma's illness, but had no history of depression or anxiety and no history of similar episodes. Here's her ECG, and I'll put up the actual interpretation. Sinus tach, low anterior forces, slight ST elevation in anteroseptal leads, and a nonspecific ST and T-wave abnormality with no prior ECGs available for comparison. So the ED doc says, I don't know what's going on here. It seems screwy. It doesn't seem likely that this was, anything cardiac, but there's just enough here with the history and the defibrillation and this ECG. Let's just get a triple rule out CT and make sure there's nothing urgent happening. So these are sort of oblique axial images down the long axis. So here's aortic root, left main, left anterior descending. What I'll draw your attention to as we scroll up and down is the proximal LAD here. It just keeps on going further than you think it should. And we'll take this now into a long axis. And again, what you see here is that the lumen is expanded out further than it should be. And there's actually a little shelf of intima here. So this looks like a coronary artery dissection here, with a kind of expansion here of the false lumen. And this is somebody who otherwise might have been blown off, right? Because her pretest probability of atherosclerosis is extremely low. And there probably wasn't enough here that anyone's going to send a young woman with a low pretest probability of atherosclerosis to the cath lab based on what we had so far. But I think there's a big difference in this case, between having a lesion like this and, it's just in your head. It's an acute sort of mental thing. This patient actually did go to cath, which confirmed here the lesion, which you see, this coronary artery dissection. You see the little intimal shelf and the expansion. And we actually used CT to follow this patient subsequently and look at the remodeling of this. Let's move on to a couple complications now. This is a 78-year-old man with a known prior MI 3 years ago. They were unable to cross the RCA occlusion, increasingly dyspneic on exertion, went for a repeat coronary angiogram, had a large akinetic inferior wall segment seen, so was sent to MRI to assess the LVEF and viability of the inferior infarct. This is the prior LV-gram, which you can see here, and this is from a RAO caudal view. So this is the inferior wall, which is akinetic, maybe slightly dyskinetic, certainly not normal. And it looks perhaps even a little worse now. There's a subtle wall motion abnormality and subtle finding here with this sort of ballooning out of the entire inferior wall. It extends all the way back to the mitral annulus, certainly containing a large amount of thrombus here. You see how wide this segment is, and there was some debate, among those of us who were looking at these images, whether this was an LV aneurysm, whether this was an LV pseudoaneurysm. I think, there's an argument that, either way, if you want to restore some ventricular function and prevent, embolic events from the left ventricle, this is going to have to be surgically repaired. So it may be a little bit of an academic kind of discussion, but certainly it's complicated for a surgeon to take out all this, again, all the way back to the mitral annulus back here and contemplate that. You see how ballooned out this really looks in a short axis image here. We'll play this again. It's just pretty remarkable. And again, this thrombus here on the perfusion image. And delayed enhancement didn't really help very much. You certainly see that there's some delayed enhancement around all the outside of this thing. And ultimately, this patient did go to surgery. And as they're elevating the LV apex up here, you can see the right-hand part of your image is where that inferior wall is. And they had to open it up and go all the way back to the mitral annulus. And this is all the thrombus they had to dig out of this thing, and tried to put a patch here to reconstruct the inferior wall, and had to be very careful to approximate the mitral annulus again. And interestingly, this turned out to be neither a aneurysm nor a pseudoaneurysm. What this actually was they called it a myocardial dissection. It's essentially a partial thickness rupture here in short axis that just ballooned out. There was actually intact uninfarcted myocardium around the outside of it here. It's just too thin for us to really see, but it was a partial thickness rupture that then just ballooned out and splayed the edges so far apart that eventually the patient, presented with kind of a worsening failure of this ventricle. So kind of interesting case to keep in mind, and I think we're seeing more and more of these that, some people are calling aneurysms and some are calling pseudoaneurysms, are actually partial thickness ruptures, or what the pathologists sometimes call ventricular intramural dissections. It's kind of an interesting phenomenon. So there's a patch being put in. And I think in our practice, we're seeing more and more CT being used for all sorts of indications that we just never would have thought of it before. And I think it's to patients' benefit. This is an example of somebody who had an infarct in the lateral wall of the left ventricle that was picked up on CT that had been missed at nukes. And of course, if you look, trying to magnify at about the same, level of magnification on both the nuclear image, the sestamibi here, and the CT, it's not a surprise, because for two reasons, of course. One is the spatial resolution of the CT is so much higher, and you can see also the fact that the negative blood pool contrast in the left ventricle, it doesn't allow you to see a dark, infarct against dark blood pool, whereas on the CT you have a positive contrast between the myocardium, the LV cavity, and the infarct. And so the spatial resolution and the positive contrast really help you to see something. In this case, again, with retrospective gating, you can also get a sense of the wall motion abnormality. Not overwhelming, but certainly when you know where to look, it comes out. And in addition to that, this is somebody who had an infarct that was not just missed at nukes, it was also missed at cath. And we can see this. I've tried to line up the CT images here, the first OM branches compared to a cath. And, I think the real benefit of the CT is knowing the myocardium, what that looks like and where this wall motion abnormality and perfusion defect are, tell you where to look on the CT at the luminogram. And I think it's a lot easier to see this kind of subtle dissection which occurred here in an OM branch than it is on the cath, where you kind of lose it in all the squirrely little branches that are kind of difficult to evaluate, I think, in this case. So the fact, again, that you get sort of direct assessment of the myocardium and the coronary luminogram from a single exam that are perfectly co-registered has been extremely powerful. And we're seeing more and more utilization of CT in our practice for these sorts of difficult cases. And that includes also things like embolic disease, for example. Well, that's my list of cases I prepared for this webinar. I'm hopeful that we have some other people on the call here who are willing to share cases from their institution.
Thank you, Phil. That was really great. So if anybody has cases that wants to share, this would be a good time to unmute and raise your hand. If not, I can show a couple cases. And before we move on, let me see if I can get my screen back.
It's Carol Denny here. I just had a question. It looks like you don't beta block anyone. You're not, unless you're specifically you specifically want to look at the coronaries. Can you tell me about your experience? Like what do you do with the patients? You just put them on the table and scan them?
Yeah, that's a great question. So we do avoid beta blocking in the ED setting. Part of the reason is to not affect the throughput of the practice. That was to get the buy-in from the ED. You know, they didn't want us to spend 20 minutes getting somebody's heart rate down and kind of gum up the system for the rest of the patients that have to come through. And we have enough traumas, of course, like everyone does, and neuro cases and whatnot. So that was part of our agreement with them. I will say again, we're fairly aggressive users of retrospective gating. We use other forms of dose reduction with tube current modulation, iterative reconstruction. But we find that, number one, that bails us out in terms of the heart rate. But number two, it makes us much, much more confident in evaluating some of these screwy things that come along, like embolic disease, coronary dissections, non-ischemic cardiomyopathies, valvular disease. And that's just sort of a practice decision that we've made, that it both increases our ability to provide useful information. They don't have to get an echo afterwards to assess LV function, but also I think it's made us a lot better at being able to have a wider data set to be able to evaluate throughout the cardiac cycle and evaluate for the coronaries in multiple phases. And I think we rarely have non-diagnostic exams, even in patients with atrial fibrillation or very high heart rates.
And if you have a dissection, when do you do the abdomen? Like, do you include the abdomen on every scan, or do you just look at the images and then do a delayed scan and re-inject for the abdomen, or what's the protocol?
Our default chest pain is not to include the abdomen. We do have it as an option for the radiologist to add an ungated abdomen pelvis CT immediately after. There is a protocol the techs can pull where it's a gated CTA chest and then an ungated abdomen pelvis with the minimum delay possible. And there's a little bit of venous contamination, but certainly for the aorta and the iliacs, it's not an issue, or the major visceral vessels, the proximal ones anyway. But that's at radiologist's discretion. The majority of the time we do not include the abdomen and pelvis, but in our practice, only about 2% of the studies that were ordered for dissection were positive anyway. So, in most of those cases, it's not a concern for us.
Okay, thanks, Phil.
Yeah.
Perfect. Thanks, Phil. Those were great cases. Quick question. So your first batch of cases, you were showing incidental, basically not incidental because the patient was symptomatic, but you were showing areas of ischemia or remote infarcts in the subendocardium mostly. And those were, you're doing mostly triple rule out. So your injection protocol is very specific to both enhance the pulmonary arteries and the aorta and cardiac chambers. We seem to have a significant number of cases that come to the ER where we do PE protocols only, where we're really trying to optimize enhancement of the pulmonary arteries. And so there's a lot of contrast that's concentrated in the apex of the right ventricle as it's coming in from the SVC and bounces back into the PA. And it creates a fair amount of artifact, I feel, in the subendocardium of the apical LV. Has that been your experience? It seems like I look for it. I see this attenuation defects in the LV, myocardium, and subendocardium, but I end up always kind of blowing it off as mostly, strict artifact from the concentrated contrast in the RV. How do you?
I totally agree. I totally agree, and I think that's one of the pitfalls, right? It's easy to overcall, certainly on a PE study. I think that in my opinion, we probably overemphasize opacification of the pulmonary arteries for some PE studies. I think that, when you do that approach, you can get beautiful images, but if it means you don't pick up the aortic dissection or the heart attack, I'm not sure how valuable that is to the patient. In our practice, we took a dissection protocol and added the second injection of about a 50-50 mix of contrast and saline for the chaser. So it's initial 80 cc's followed by a 40 and 40 mix of contrast and saline. And I think we get good pulmonary artery opacification. Is not as aesthetically beautiful as a traditional PE study, but certainly good enough. And then when you have that later delay, I think it's easier to see things in the aorta or, for example, the coronary arteries. And for us, it's become a more comprehensive exam that our cardiology group has been very receptive to.
Great. What kind of scanner are you use? What's the temporal resolution on it?
So we use second and third generation dual source, Siemens flash and force scanners.
Got it. So
the through plane resolution we reconstruct is 0.6 at 0.3 for the coronaries.
Okay, perfect. Yeah, so that definitely helps because most TRs, they don't necessarily have the high-end scanners. They have more bread and butter older scanners, in my experience.
Yeah, no, we just happened to have installed those, and I think we pretty quickly figured out that the big difference between the handful of triple ruleouts we were doing and the dissection studies, the biggest difference was 40 cc's of contrast and whether we looked at the heart or not. And the CPT code we were using was the same. The radiation dose was comparable. The biggest difference was, are we looking? And I think again, that we got a lot of direction from our clinical colleagues that the value you could provide by sort of trying to capture a more comprehensive exam up front really had downstream impacts for clinical care.
Perfect. Thank you. All right. So again, if anybody has a case they want to share, send me a note or just unmute yourselves and request to the screen. In the meantime, I wanted to show two cases, but I saw that Phil had one, and I have one here that's a nice companion. So I'm going to show that that's a third case. So let's start with that one. So this is a young patient. And again, just a quick show and tell here. And this was the incidental finding. And you can see right away here, the left main coronary seems okay, but as soon as it bifurcates, you can see that it starts to become ectatic or slightly aneurysmal. Same here in the right coronary. It became also aneurysmal on the CT examination. So this was a patient also with Kawasaki's disease. So again, just I guess it's another companion to the one that Phil showed. It does not seem to have any critical narrowings to explain any symptomatology on this patient. But again, another case of Kawasaki. So we do tend to see them actually in the younger population. And again, when the patients are older, clearly the most common cause is not going to be Kawasaki anymore, but just atherosclerotic related aneurysmal dilatation of the coronaries. Okay, so I found two cases that I wanted to share because they're kind of similar, and I think they have very nice teaching points. So case 2, let's start with case 2A. And let's see which one is the best sequence to show. So you can tell right away here it was done at the 30% of the R2R cycle. So this is in systole. So this was a TAVR examination. So this is pre-TAVR, looking for the anatomy, measurements of the annulus, etc. And one thing that was noted in this examination and was mentioned in the report was this very coarse, dense calcification at the top of the annulus in relation with the non-coronary cusp. I'm going to window it a little bit more closer to the bone window so you can see it there. So not only does the patient have calcifications of the valve commissures, but it also has calcifications associated with the annulus. And again, that was mentioned in the report separately. And patient went to have the procedure and decompensated and actually made it back to the scanner for more images. Usually these patients, we don't get to scan them afterwards. And you can see this patient was intubated there. You see the endotracheal tube, the NG tube as we go down. Now the patient has also central venous catheter. Patient, as you saw on the other images, had prior coronary bypass surgery. But now we also see this large collection here, posterior to the aorta, here, and between the aorta and the left atrium. And there's a TAVI in place. Here, all that calcification. So this patient developed a large contained pseudoaneurysm after TAVI deployment. Is one of the known, not very common complications. With the rupture of the annulus, this one got contained, thankfully for the patient. These are coronal reconstructions. And again, as we move back, you see this large contained collection here behind the annulus. So a complication of TAVI, and you can kind of see there where it's communicating there where the annulus ruptured here at the edge of the valve. The other case that's similar, it's this one. This is also post-TAVI, it's just a without this. And this is, if you go down, again, we don't get to image these patients very often on the scanners. You can see a few things, but the first thing you notice is the valve. And if we window appropriately, we can see right away, again, a large burden here of calcium, exactly the same location in the top of the annulus adjacent to the non-coronary cusp. But the other thing that you can see here, I'm sorry, let me try to, this thing is very sensitive, okay? If you look, there's a pericardial effusion now, but it's about the same density as the heart. And if you were to measure, let's see if this works. If not, I'll just tell you. If you're looking for the Hounsfield units without grabbing the epicardial fat there, it's on the higher side. I was measuring up to 60 on my PACS system earlier. So this is consistent with a hemopericardium. So there's some blood by peroxis there after TAVR. So probably a small rupture at the time of implantation as well. So I wanted to show these two cases that had that calcium in that area. And let's see, I did have a paper to share with you guys. So it was published just a couple of years ago by a group of authors. We know some of them. They're all friends of Nasky, of course, like Jonathan for sure. And this is the title of the paper, is the impact of calcium volume and distribution in the aortic root related to the injury after TAVI, specifically dose balloon expandable like the SAPIEN, which is the case that the two cases that I showed you. And what's important here, what they showed here is they took all these patients, they did this analysis, and then they measured the amount of calcification at different levels, most importantly, right at the level of the annulus and then below the annulus. And you can see here on the coronal reconstruction, sagittal reconstructions, those levels. And what's interesting here is what they showed, and you can see here, these are cases similar to the one that I showed you, all this calcium burden at the top of the LVOT in relation to the non-coronary cusp. And when you look at their ROCs here, so these two graphs, let's look at them. This is the ROCs for the predictive value of calcium volumes for aortic injury. They did two analyses. The first one here is the aortic valve calcium volume, the upper LVOT calcium volume, and overall. And you can see the blue line, which is this top line. That's the one with the highest R value here for association with annulus rupture. So that the calcium in the upper LVOT, much higher than the aortic and much higher when you combine everything together. And also interestingly, when you just take that upper LVOT calcium score and you look at the way they did it, and they looked at below the non-coronary cusp versus the right coronary and left coronary cusp, in blue again, significantly higher risk when that calcium in the LVOT, upper LVOT, associated to the non-coronary cusp, like the two cases that I showed. So I think that's why it's important to mention on the reports that we're doing, when we see that characteristic volume and distribution of calcium, that puts at risk those patients. So we should warn the clinicians to be, careful when they are deploying these balloon expandable valves in that area. So those are the two cases plus one that I wanted to show today. Again, everyone is invited. Is there anybody else has a case there to share?
I have one interesting case I can share.
Well,
I don't know if it'll measure up to what I just saw from you and Phil, but I do have something.
I'm sure it'll be fantastic. Let me see if I can share the screen. Give me 1 second. We're all learning how to use this. All right, Greg, I'm gonna make you presenter.
Okay.
Perfect. Thank you, man. There you go.
Okay. I think I've got is that my case there. Are you seeing the case?
I am.
Okay. All right. Okay, so this is just one quick case I want to show as something quite interesting. As you can see, this is not a cardiac CT, it's just an enhanced CT, but there's an interesting cardiac finding here, which some people maybe have come across in the past. The reason I like this case is it's quite a unique appearance of calcification within the myocardial wall. It is not subepicardial. It is mid-myocardial or epicardial, and it is diffuse everywhere, preferentially in the LV. Maybe there's a small amount occurring in the RV, and this can create a lot of confusion when someone comes across this. This condition is diffuse calcifications of the myocardium that can either occur because of chronic renal disease, or it can occur in the setting of sepsis. Although in my experience, I have maybe 3 or 4 cases like this, and they've only occurred in situations of sepsis in patients who also had chronic renal disease. So this person, they are on dialysis. They were admitted to the ICU. They had a septic episode, and then there are the I don't have the pre-images with me, but these are the calcifications that appear. And I don't remember the time course in the literature for the appearance of the calcifications, but it is on the order of something like 10 to 14 days where you get the appearance of these diffuse calcifications. In the few reports of this disease, it's described that these patients, most reports describe that there's normal cardiac function, and this patient did have normal cardiac function on echo. There was one case report out there where they described that the person subsequently had decreased cardiac function. But you have to remember, these are patients experiencing sepsis, so it may have nothing to do whatsoever with the calcification. And that's it.
No, thank you, man. That's a pretty good case. Okay. All right. Anybody else? Or any questions to Dr. Kishka? All right. Well, I want to thank everybody for joining us for our NASCAR.
Actually, one quick question for Greg.
Yeah, go.
Yeah.
Did the patient have any diastolic dysfunction that developed with that kind of calcification?
Oh, I don't know. That's a great question, Phil. And believe me, I would love to know that. So, but there's no evidence on echo. But as you know, this person didn't exhibit any symptoms of volume overload. And, you know, it's very difficult to diagnose diastolic dysfunction. Whether any diastolic dysfunction is truly there, I don't know. Other case reports have not discussed that, but that is something that I do wonder about.
Yeah, you would think. So the question is really, does it have any restrictive effect on the heart, the calcification?
Correct. And this has only been described, I think there's maybe 10 reported cases, but I'd say we see something like this maybe every 18 months we come across a patient like this. Usually when people see it, they panic, they don't know what it is. It's grossly abnormal, particularly on an unenhanced study. But the patients that we've seen have not had any reported cardiac dysfunction. But again, if there's underlying diastolic dysfunction, I could see how it would not be, like it would just be missed.
Perfect. Great.
Do you guys recall seeing these type of cases?
I think I've seen it once, a long time ago.
Mm-hmm.
And I don't remember much of the history, to be honest with you, of that patient.
Yeah, we have a couple too, and like you, there were renal patients who had underlying renal insufficiency.
Right.
Yeah, I've seen 3 or 4, and they all did, and they had sepsis. So all very similar histories.
Maybe we should pull them all together and see if there's something more we can learn about them.
Mayor, this is Diana. We have seen a case or 2 like that. We actually were trying to submit it for publications, but didn't have much luck. So maybe a series of cases would do it.
Okay.
Hey, this is Stefan. You know, we actually have a paper in JCCT that I did with Jay Nance that has, I think we had about 6 or 7 cases. We saw them in the same kind of scenario, and also we had some pediatric cases also. One like a post-transplant kid, also with sepsis, and another kid with severe myocarditis, but all very similar stories, you know, sepsis and renal dysfunction.
Mhm. Okay.
Thank you.
Perfect. Great. Thank you, guys. All right. Well, again, thanks everyone for joining. See you next month. Prepare your cases. The quorum continues to increase every time we do this. Hopefully, it's helpful, useful, and a good, meaningful experience to everyone. So again, thank you very much, and thank you for being part of NASCI.
Thank
Yeah,
you.
thanks, guys. Those cases were amazing.
Thank you.
Thanks, bye.
Thank you.